Good afternoon. So last talk before lunch, always my favorite. I've brought my phone up here so I can make sure not to go over too much. So thanks so much for having me. This has been great. I am getting to see a lot of, again, not chronologically old friends, but friends that I've had for a while. And Dr. Gibson, I'm still keeping your office warm from when you left us at UNC. I graduated from a cubicle to an office with a door when Dr. Gibson left us. So I was sad in some respects, but in others, I got an office with a door. So thanks so much. Okay, so I am a transplant nephrologist, but I also live in a place where glomerular disease reigns supreme there at UNC. So I'm always happy to talk about two of my favorite topics. So this is a real problem, and why is it a problem? Well, we talk about recurrent glomerular disease, but it's really many, many different diseases that recur. And of course, the pathophysiology of all these diseases is quite different. Depending on where you are, what your transplant numbers are like, what your follow-up is like, you may only see 2 or 3 or 4 cases of recurrent glomerular disease. Some of the diseases are quite rare in the native population, so needless to say, post-transplant can be even more rare. So it's hard to get a sense as an individual practitioner or an individual center what exactly to do with these patients. Unfortunately, even though we use a lot of the same drugs in transplant that we use to treat native glomerular disease, we use rituximab, we use CellCept, calcineurin inhibitors, it doesn't seem to completely prevent recurrence post-transplant. And just like in native kidney disease, when a patient has a transplant and they have an increased creatinine because of recurrent disease, we know that impacts their mortality, impacts their morbidity, and can lead to graft failure. So you have patients that have already struggled through a native glomerular disease and all that entails, and now here they are, arrived at transplant, the disease comes back, and we're kind of down this road again. And all of the immunosuppression and therapies and comorbidities and things that entails. And just like we've talked a little bit about, the treatments, we don't always know what to do in native kidney disease, let alone in the transplant setting. So this is from some Australian and New Zealand registry data. They have about 40% of their end-stage renal disease population has glomerular disease, so they have a lot of data about patients that have recurrence. So recurrence is bad regardless of the cause of your glomerular disease. This is descent or graft loss, and overall graft loss, again, much higher in patients that have recurrence. This is older data from that same group that looked at all-cause graft loss, and recurrent disease was the third leading cause of graft loss, so 8% of their patients, again, a higher percentage than we see in the U.S. of glomerular disease, but second only to rejection and death with a functioning graft. So significant graft loss in a situation where we can't afford to lose kidneys because we surely don't have enough to go around. This is a problem that has become more prevalent as we get better at making kidneys transplant last longer from things like rejection. We're having patients live longer. We're better at cardiovascular disease, but we haven't gotten a lot better at treating recurrent disease. So it starts to become more of a problem that we're dealing with, and particularly in our younger patients. So this is 15 to 54 years. It's not as big of a problem in our more advanced age transplant patients. And this is a big deal because our young patients, as it stands, are probably already going to need more than one transplant in their lifetime, regardless of whether they have recurrence. So we certainly don't want their graft survival to be shortened in any way. So I will attempt to answer some questions for you when it is possible to do so. So we'll go through some of the glomerular diseases, talk about what the risks of recurrence are. So when we talk to our patients, it's so important for them to understand that these diseases can recur. What is the risk? What should they expect after transplant? What are the risk factors for recurrence, if there are any? How does recurrence look in a kidney transplant? Does it look different than they present in their native disease? What time frame would we expect to see the glomerular disease to recur? What can we do to prevent it, if anything? What's treatment, if there is any treatment? And once the disease recurs, what's the risk that their kidney may ultimately fail from recurrent disease? Whether the impact of the donor source, so whether it's an unrelated living donor or a related living donor, is there a difference there, or versus a cadaveric or deceased donor kidney? Sometimes that can affect, particularly in some recurrent diseases that have a genetic aspect. And with regards to the course of their native disease, how do we figure out when is an appropriate time to transplant these patients to hopefully decrease their risk that their glomerular disease will recur? So these are not all of the glomerular diseases. There are certainly more. 45 minutes isn't quite enough time to go through all of this in detail, so I'm going to really try to hit what I kind of consider the big three, which is FSGS, membranous, and IgA, and make some comments about some of these other glomerular diseases that are a little less common. Of course, I have to talk about ANCA because they'll lock me out of UNC if I don't do that before I go home. So first, let's talk about FSGS. So FSGS doesn't have the highest rate of recurrence of all the glomerular diseases. Actually, MPGN does. But because it's so common in our transplant population, you are likely to see it if you take care of kidney transplant patients, particularly if you take care of younger kidney transplant patients. So what is the risk of recurrence? Well, it quite varies depending on, of course, what sources you read and what your patient population is. So for my patient population, the older folks, it's more down the 20, 25, 30% range. For you guys in the audience that take care of our little ones and our teenagers and young adults, it's much higher. And certainly the risk of recurrence of secondary FSGS depends on the underlying disorder, which I won't discuss that. So what are the risk factors for recurrence? I've already alluded to young age as a risk factor. So this is something we look at very intensely in our pediatric and young adult population. Also, the course of their native disease can predict recurrence risk. So if patients had a native diagnosis of FSGS and progressed to dialysis within 3 years, that's a much higher risk for recurrence. If you have their native kidney biopsy and it showed mesangial proliferation, that is a risk factor, non-African American race, and certainly anyone who's lost a previous kidney transplant from FSGS is at a high risk with a second transplant. Oh, so what is the pathophysiology of recurrence of FSGS? Well, isn't that the million-dollar question that we've been talking about ad nauseum for as long as I've been in kidney transplant, which is getting longer. I used to feel like it wasn't that long, but now as I'm getting older, it's been a while. So for many years, we've talked about this potential circulating factor that causes recurrence of FSGS. And why do we think this is a thing? So presumably something in the serum that is attacking the kidney transplant to cause recurrence of FSGS. So some of the data that supports that is FSGS can recur immediately. It can recur, it's been shown to recur in the PACU in a patient recovering from their transplant surgery. So immediate heavy proteinuria. So that suggests that it's not something coming with the kidney, it's something present in the serum of the patient that's attacking the transplant, almost like you would see in hyperacute rejection with preformed antibodies. Our morning speaker was talking about plasmapheresis and that some of our patients with recurrent FSGS respond to plasmapheresis, suggesting we're removing something from the serum that's causing the pathology. We know that serum from FSGS patients can cause increased albumin permeability when transferred in an animal model situation. And there has been a case report that was in the New England Journal here where a patient had immediate recurrence of FSGS that was severe, was not responding to therapy. They actually explanted the transplant. So they took the kidney transplant out and gave it to somebody else who did not have FSGS, and the proteinuria went away, and the kidney actually lasted quite a few years. So something there. Again, we've alluded to just in discussions today that there is probably most likely FSGS being more than one disease. So does everybody have a circulating factor? Do I think some patients have a circulating factor? Yes, I do think so. Does everyone? Probably not, and I'll show you why I think that is. And certainly there are also some role of T cells. There's genetic factors that do influence the risk of recurrence. So as I alluded to, we do think in some patients there's a circulating factor. Well, what the heck is it? Who knows? So many people have looked at many different things, and here and then things gain excitement and we think, oh, this is it, we found it, and then it doesn't really pan out. And that's kind of been the case with SUPAR, which, as she talked about this morning, there was an initial very well done study in Nature Medicine back in 2011 where the investigators showed that this soluble urokinase receptor in the serum was highly predictive of recurrence and showed that lowering that SUPAR level with plasmapheresis ameliorated the disease. However, in subsequent studies, other people looked at this assay and found that there was actually no difference in levels in other glomerular disease. Other patients with kidney disease had increased levels of SUPAR and they were not nephrotic. And it may be that just SUPAR may be another marker for CKD that's elevated in CKD and not necessarily the pathogenic thing. So currently, at least in our institution, we're not using SUPAR measurements for clinical decision making. And again, there's probably not necessarily a single permeability factor, or certainly that's not necessarily a role in all of the patients that have recurrent FSGS. I'm not going to belabor this point, but genetics can help us know who's at a lower and higher risk for recurrence post-transplant. So how do these patients present? I told you this can happen early. It's often associated with massive proteinuria, but also early in the process can be quite subtle. They may have hypertension, graft dysfunction. As I mentioned, it can happen immediately, but almost always happens within the first year or so after transplant. If you are an aggressive center or a center that does protocol biopsies, if you biopsy early in their disease course where their proteinuria isn't very high, you may not see any changes by light microscopy, similar to like a minimal change disease. So it's important when you're doing biopsies of patients who have a native glomerular disease is to include electron microscopy in your pathology request, because a lot of pathologists in the first year only do light microscopy and immunofluorescence, or they may not do electron microscopy. So at our center, we're very aggressive to do electron microscopy, certainly if there's proteinuria present or if they have a history of native glomerular disease. Now, FSGS is not only a disease, but it's also a pathologic finding. So we see a different process, de novo FSGS, in transplant patients as well. So you want to try to make that distinction. It's much milder generally. It occurs later. If you see a collapsing FSGS lesion on a kidney transplant biopsy, those can be associated with infections, which certainly our patients are at risk for infection. So want to rule out things like HIV or parvo B19, which can lead to that collapsing lesion. So therapies for recurrent FSGS also has been a bugaboo in transplant world. So certainly you want to do things to reduce proteinuria. We know that's good in any glomerular disease. Particularly in the pediatric population, high doses of cyclosporin have been used for their antiproteinuric effect. You have to, obviously we use calcineurin inhibitors in most patients post-transplant for prevention of rejection, but not to the trough levels that you would use in a patient with recurrent FSGS. So shooting for much higher troughs. And then often in combination with the mainstay of therapy for recurrent FSGS, which is plasmapheresis. Just like if you look into any case or series or reports of plasmapheresis and recurrent FSGS, you will see that the numbers are typically very small. They tend to be case series from single centers because there's never going to be a randomized controlled trial of plasmapheresis and FSGS, because I don't think any transplant nephrologist would feel comfortable enrolling their patient in a trial that didn't include plasmapheresis as part of the therapy. So this conglomeration of case series showed a response rate of about 63% to plasmapheresis for recurrent FSGS. As I mentioned, this was a small sample size. These were single center series. There weren't a lot of inclusion of a comparator group. How remission was defined was different. The follow-up was short-term, so maybe overestimating the benefit of pheresis. And I certainly personally haven't experienced a 63% response to plasmapheresis in some of my recurrent FSGS patients. I sure wish. That would be great. We do know the earlier you start it, the better chance for success. If you already have sclerosis on the biopsy, that does predict treatment failure. We were discussing early about plasma volume tends to be 1.5 times volume with albumin replacement. It can take patients a long time to show a benefit, so consider if someone at least has a partial response of continuing pheresis, because sometimes down the road they will reduce their proteinuria some. And I do have one patient, I think we all kind of have that one patient or two patients that's doing this sort of long-term pheresis course. I have a guy, he's a young guy with recurrent FSGS. He gets one pheresis treatment a month, which makes no sense pathophysiologically if you listen to the antibody lecture from earlier about pheresis. But if we try to go any longer than 4 weeks, his proteinuria comes back. If we keep him once a month, it stays at 1 gram. I cannot explain to you why this is, but there are, I think, a lot of stories like that out there. For some reason, that seems to work. There is a little bit of data about using plasmapheresis prophylactically in patients at high risk for recurrence of FSGS, and I think that's done quite a bit in the pediatric population. This is using it prior to the actual transplant event. So obviously much easier to do in a living donor situation, but if you can mobilize your pheresis people soon enough in a deceased donor transplant, you could potentially do some pheresis prior to transplant. This was 10 patients at high risk. They got 8 treatments perioperatively, so I can't exactly remember what the breakdown of pre and post actual surgery was, but had a much lower rate of recurrence than you would expect from a similar population that did not get preemptive therapy. But you still got 30% recurrence. So you can see that in these high-risk patients, it's a real problem. There have been studies looking at prolonged combined therapy, so high-dose cyclosporin together with prolonged plasmapheresis with good results, but again, very small numbers. But, 90% remission is amazing. But again, I don't know that that would bear out in a larger study, but much better than at least in their hands of their historical controls. We talk about rituximab and really yes?
In the prolonged combined, is that with the steroid sensitive or the steroid resistant or all cases?
It was all comers, I believe. I don't know for sure. But that's not always known when they come to us, how their course was and their original disease, particularly if it's a deceased donor transplant and they've been waiting on dialysis for 5 or 6 years. We don't always know. The patients don't always know. So I'm not sure that was defined in that study, but I'd have to go back and look. And I'm happy to share these slides with the references for anyone that wants them. So we talk about rituximab in just about every glomerular disease. I think it's had sort of iffy response in recurrent FSGS. There's been a little bit more positive literature lately. This is an old slide, but shows a patient who didn't respond to other therapies, including pheresis, MMF, cyclosporin, got rituximab with amelioration of proteinuria. This case series, as the one I showed you with pheresis, had a pretty robust response at 58%, another reported 64% response to rituximab. We dose it as you do in other glomerular diseases, either weekly for 4 weeks or 1 gram, 1 or 2 doses. Some things that predict response to rituximab or a normal serum albumin at the time of recurrence, a younger age, and the need for less doses of rituximab, so really milder disease kind of is my take of that, responds better. And can certainly combine it with plasmapheresis. As mentioned earlier this morning, you have to be careful not to pherese off your rituximab because it is not cheap. It's cheaper than eculizumab, but it is not that cheap. And some centers have used it for prophylaxis. Again, you have to see how you feel about the data with regards to rituximab. We have not used it for recurrent FSGS at UNC. We feel like it's not the data isn't as great as we would like for the trade-off of the infectious complications. I'm not saying I wouldn't be a little more open to it. I think in the past the data hasn't been as good. I think there's been some more positive data more recently with regards to use of rituximab for recurrence. So what are some of the other therapies that have been put out there for recurrent FSGS? We have belatacept as a B7-1 blockade, so a close stimulatory blockade that we use in maintenance immunosuppression. There was some earlier studies that showed some case reports where it was helpful in patients with FSGS, but a subsequent prospective trial didn't show any difference, so that really hasn't been borne out. There's some data that suggests that galactose may interact with a permeability factor, so that's been used in a few case reports. As mentioned before, anti-TNF alpha may play a role, so those medications have been used, or TNF alpha may play a role, so the anti-TNF alpha drugs. Again, case reports, and then as mentioned before, ACTH or Acthar has been used in a few case reports with some success, and a fairly benign drug to use, so certainly some ongoing research there. So in those patients that have recurrence, unfortunately, the risk of graft loss is pretty high, up to 50 to 80%, and very high in a second transplant. That's not to say we wouldn't do a second transplant in someone who had a recurrence. You would kind of look at what the sort of their course of their recurrence was in their initial transplant. If it happened very quickly and was very aggressive, there's no great data to suggest, but some people say, well, you may want to wait a year or two, presumably to let whatever factors were causing that recurrence, whether it be a circulating factor or what have you, to sort of diminish before attempting another transplant. And in those patients would absolutely consider some preemptive therapies such as plasmapheresis, rituximab, what have you. And it's important for a living donor in this situation in a second transplant where the first was lost to FSGS as part of their education to know that this is a graft that's at a high risk of loss, and to have them going into a living donor situation with eyes wide open. So moving on to membranous nephropathy. So again, depending on the source that you read about the risk is whether or not you are looking at data from a center that does protocol biopsies. So certainly people who do protocol biopsies will pick up membranous nephropathy recurrence at a much higher rate than people who do them for clinical reasons. So while there are no clinical risk factors, demographics, things like that have been identified, potentially the presence of anti-PLA2R antibodies may be something that we can start using as a risk factor, and I'm going to talk about that in the next few slides. Patients can present quite subtly with membranous recurrence, and particularly in these protocol biopsy series, patients presented with really mean protein excretions that are barely above normal, 331, 575 milligrams per day, with much pretty normal-looking creatinines for a post-transplant patient. Again, presumably, if they went on untreated, they would potentially be more nephrotic, but also remember these patients are on maintenance immunosuppression, so it may just be that we're picking these up because we're doing protocol biopsies. Most patients that have recurrence will be within the first 1 to 2 years. So as Carla already mentioned in her talk, we know that 70 to 80% of idiopathic native kidney disease membranous nephropathy is triggered by these autoantibodies against podocyte proteins. The one that I will discuss and the one that's mostly in the literature right now is the PLA2R receptor or N-phospholipase A2 receptor. The other, which I'm just going to say THS-D7A, has also been shown potentially to, high titers of this pre-transplant has been shown to associate with post-transplant membranous recurrence, but I'm not going to present any of that data today. So we know that in native kidney disease, the levels of these antibodies do correlate with disease activity, and that we can stain the kidney biopsy for PLA2R even when the immunological disease has gone away. So it's sort of permanently there. You can actually take a patient who has been biopsied in the past, go back and stain that biopsy for PLA2R, which can be helpful when you're monitoring them post-transplant. So I'm just going to put out a couple of studies. This one is a little bit older, but they looked at 10 patients with recurrent with membranous nephropathy that had PLA2R antibodies present in the serum at the time of transplant. Now, of those 10, only 5 of them had recurrence, and 5 of them did not. None of the patients that had de novo membranous nephropathy, which is not felt to be associated with PLA2R antibodies, were found to have that post-transplant. So that made sense. But why did some of these patients who had a positive antibody at the time of transplant not have recurrence? And I'll tell you why. There are some explanations as why that may be in a minute. This is some other data that's a little bit more recent where, again, they looked at patients pre and post-transplant. 12 of them had anti-PLA2R antibodies at the time of transplant. 10 of them recurred, so at 83% recurrence rate, and those that were positive for anti-PLA2R antibodies. In those that were negative, the recurrence rate was lower, but it was not 0. It was 58%, so actually kind of on the high side. And why might that be? So there's some explanations as to why they might be. As far as why people with antibodies present at the time of transplant, why they don't recur, it may be that we're treating them with the drugs that we use at the time of transplant. So if you're using strong induction therapy, high dose immunosuppression, particularly in that first year or two when the risk of rejection is high, we may be inducing remission of their membranous nephropathy. We're looking to get rid of HLA antibodies. We may be getting rid of these anti-PLA2R antibodies as well. There's some have suggested that the transplanted kidney may have a different epitope, and therefore that the anti-PLA2R antibodies from the native disease don't actually recognize the epitopes on the new kidney. It may be that there's recurrence that's subclinical that we're treating with other drugs. So in that case, they may have a recurrence that's just not picked up unless you're doing a protocol biopsy because the level of protein is so low, you're using ACE inhibitors already. So if you did a biopsy and stained it, you may see it, and that's why we're not picking it up in these patients that had antibodies at the time of transplant. And on the flip side, we know that not everyone that has native kidney disease from membranous has an association with PLA2R. So some of these patients that were negative for it at the time of transplant that's recurred may have a different antibody that's not PLA2R associated. So what do we do with these antibodies now that this is becoming more readily available to us? The staining in the biopsy is becoming readily available. How do we use this in our transplant toolbox? Well, you can certainly consider measuring it pre-transplant just to classify as to whether a patient with native kidney disease has PLA2R associated disease or non-PLA2R associated disease. If it's been a while, if they've come to you and they've been on dialysis for 5 years, that might not be a useful test, but if you could get your hands on their old kidney biopsy tissue, you could stain it. I'm not sure that going to all that trouble is necessarily worth it right now. But because, at least in some patients, the presence of this antibody at high titers or the appearance of the antibody when it was previously gone may be associated, in some patients with recurrence. So certainly those are patients you may want to monitor more frequently. You may be wanting to check their urine protein more frequently or have a much lower threshold to do a kidney biopsy. And what about the patients that have very high levels at the time of transplant? What do we do with these patients? And I can tell you, we don't know the answer to any of these questions. Do you postpone the transplant until the antibodies go away? Do you take somebody on dialysis and treat them to make the antibody go away? I don't think there's evidence to that yet, but that might be something that is considered in the future. How long would you postpone transplant, knowing that being on dialysis is associated with real mortality? And is that a situation where you want to postpone a kidney transplant? Would you do different maintenance immunosuppression or induction therapy? There's some suggestion of using rituximab preemptively. And who knows, but I think these are all questions that are ripe to be answered by some research in the future. I will tell you, we are not routinely screening patients right now at our center with anti-PLA2R antibodies, but I think as more data comes out, that would be a discussion to have. So for therapy, as I've mentioned, the immunosuppression we use doesn't always prevent recurrence. We use ACE and ARB to reduce proteinuria. We treat the hyperlipidemia. We're wary, particularly in our heavy nephrotic patients, of thrombotic complications. And unlike native kidney disease, spontaneous remission of membranous post-transplant is rare. They usually require some additional therapy. Steroids have not shown to work consistently. Other things like Cytoxan as well. So our mainstay, as in native kidney disease, is rituximab. This is an old slide, but I could put a more recent study. It would look the same, that most patients do respond to rituximab therapy, at least partially, or hopefully a complete response. But it can take some time, which is why I put this slide in. The black bars here being no response, the gray being partial, the white being complete response. So you can see that the longer you are treating patients, the more likely you are to see a partial or complete response. So realize that it might not be immediate. And it's dosed as in other glomerular diseases. And as you would expect, it's better if you use it early, if there's less scarring on the biopsy, when the levels of protein are lower. So what about graft loss? Well, it varies quite widely depending on the source that you read. So some will quote 10 to 15%, some up to 50%. Others have not shown an increase in graft loss even with recurrence. This study is quite small, is 23 patients, I think, but showed a higher incidence of recurrence in living-related donors. And you could imagine if they share that epitope for the anti-PLA2R antibody, it may be putting them at an increased risk of recurrence if they are someone who had that antibody as a cause of their native kidney disease. That being said, I'm not sure I would reject a living-related donor for somebody with membranous nephropathy, but it's something to sort of just put in your decision-making process as well. Now, de novo membranous nephropathy is a completely different entity, not felt to be related to anti-PLA2R other antibodies, potentially related to humoral injury, but not clear. It's actually more common than recurrent disease. It's more indolent. We don't think it affects graft loss significantly. They tend to have a lower excretion of protein and present later. And again, these patients would not be expected to have anti-PLA2R antibodies or any of the other antibodies. Questions about membranous? I'm watching my clock. I have like 5 more minutes. Okay, quickly to IgA nephropathy, which recurs quite commonly. If you did a protocol biopsy series, about 60% of patients would have mesangial deposition of IgA on a transplant biopsy, with a less common clinical recurrence where you would actually see proteinuria or hematuria. As far as HSP, which is sort of the systemic form of IgA, the recurrence risks tend to be about the same. And again, also bore out that patients that didn't receive steroids had a higher risk of recurrence. This shows, again, fairly small numbers, suggestive that patients that receive mycophenolic acid may have a reduced risk of recurrence, and then patients that receive sirolimus actually may have a higher risk of recurrence. We know that patients that get sirolimus can sometimes have proteinuria, and we get nervous about, or I do at least, in patients with native glomerular disease because it seems to anger the glomerulus, and I don't like that at all. So with regards to prevention, thinking about whether this is an appropriate candidate for a steroid-free protocol, considering thymoglobulin induction, if that's not something that you do at your center. I think most of us use mycophenolic acid in our standard maintenance immunosuppression, but sort of factoring all those things in, thinking about this patient's course and what you can do to hopefully prevent recurrence. What are some therapies? Certainly ACE-ARB, blood pressure control, as you would in native disease. Fish oil has not been studied really well post-transplant, but it's a pretty benign thing to take, so you could certainly include that. There's data from the Asian literature about tonsillectomy for patients with recurrence of IgA. That's a pretty morbid procedure to go through as an adult and hasn't, outside of that patient population, shown to be particularly effective. So that is not something that we are suggesting or that I am suggesting that you do to your patients. The good news about recurrent IgA is that even in the face of recurrence, the graft survival for these patients is pretty good. You can see that there is a separation in patients in graft survival with patients for recurrent disease, but it doesn't really bear out until almost 10 years post-transplant. Because our IgA patients tend to have a fairly low amount of other comorbidities, they actually enjoy a better graft survival for quite some time. Here out at 17 years, it's statistically less, and this is probably starting to show the effects of graft loss from recurrent disease. Okay, I literally have 5 minutes left. So again, there's some studies that have suggested related donors may have a higher risk of recurrence, but even when that's the case, the graft survival is quite similar. So we would not discourage living donors for patients with IgA. There is, if you lose the first graft to IgA recurrence, there is an increased risk of recurrence in the second graft. But again, the graft survival is so good that it's not actually statistically different than patients who get a second kidney transplant for other reasons. So particularly if their first graft lasted a reasonable amount of time, we would still do a second kidney transplant in somebody who lost the first one from IgA. I'm going to blaze through just to make some sort of take-home points. For ANCA vasculitis, I think the take-home point that I'd like you to know is that ANCA titers, so we don't even know what to do with ANCA titers in native kidney disease, but we do know that in the absence of clinically apparent vasculitis or disease activity, that ANCA titers at the time of transplant do not predict recurrence. So if you have somebody who has a high ANCA titer and somebody's pushing back that they don't want to transplant them, but their clinical disease is otherwise quiescent, there's no reason not to go forward with a transplant because it does not predict recurrence. That being said, it still makes you nervous, and you may want to follow them and be a little more vigilant in your monitoring, but that's not a reason to deny somebody a kidney transplant that has ANCA. And the treatment for ANCA post-transplant is pretty much as it is in native kidney disease. To know, though, that patients with renal-limited ANCA can recur post-transplant and have extrarenal manifestations. So we have had a patient who presented with hemoptysis that never had hemoptysis as a part of their native kidney disease course. They did not have ANCA in their transplant, but they recurred in an extrarenal fashion. So, still treat them appropriately for those sorts of things. Just a quick word about anti-GBM disease. The risk of recurrence is incredibly low if their anti-GBM titers are negative at the time of transplant. If they recur, it's pretty bad, and they usually lose the graft. And then also patients with Alports can develop anti-GBM disease after transplant because of new antigen exposure from that native kidney, and that's a bad problem. They tend to have graft loss, and then they tend to do it again if they're retransplanted. So really, if you have somebody who has Alports and they're transplanted and they get anti-GBM disease, it's really contraindicated for them to have another kidney transplant, which is obviously devastating. Lupus, again, histological recurrence common in biopsy, protocol biopsy series, but clinically, probably one of the ones that modern immunosuppression really has reduced the severity of which we see people recur in their lupus. And if they tended to have, and obviously most patients that come to transplant from lupus nephritis have had an aggressive course in their native kidney disease, which is why their kidney failed. But the recurrence and the transplant tends to be a milder situation, probably because of the presence of baseline immunosuppression. Don't tend to see as much severe chronic disease like you do in the native kidneys, but obviously can happen. Treatment, largely rituximab and whatnot. And then one other word about lupus, obviously these patients can be at risk for thrombotic complications, so you don't want to put in a new kidney and have it thrombose. That makes everybody very, very sad. So certainly be wary of that in the pre-transplant period. We sometimes have our lupus patients see our hematologist potentially for a perioperative anticoagulation plan if they should need it. So just to wrap up, of course, not everyone that lands on our door that needs a kidney transplant that we know what their native kidney disease was from. People can show up in the ER with a creatinine of 13 and scarred down kidneys, and we never know what they had, but sometimes you can guess, if it's a young, 20-year-old African-American male, I would be worried that they had primary FSGS as their native kidney disease. So you kind of want to think about, even though you may not know, what's the possibilities, what should I look for, be wary of post-transplant, and certainly get old biopsy data and whatnot and clarify that as much as you can, because it's going to help you cancel the patient about recurrence risk and will help you in your monitoring after transplant. Certainly, if they've had a previous transplant, you want to know what they lost their graft from, because if it was from recurrent disease, that's going to affect their management and how you treat them going forward. And then, as I suggested a little bit with the data, think about, for that particular disease, is there a better induction therapy? Is there a better maintenance immunosuppression that you could choose that may help, obviously, because as we know, preventing is better than treating. So think about that when you're making those decisions. And then, again, you got to do EM on these patients because you can be surprised. A lot of antibody-mediated injury can look like glomerular disease on light microscopy. You may have somebody telling you it's AMR, but really it's recurrent MPGN, and you don't know that without getting EM, looking for those electron-dense deposits and getting all of that information. So really push your pathologist to do EM, even if that's not something you routinely do. And if I don't make any sense, it's because this little one likes to get up at like 5 o'clock every morning. So I try to be coherent, but it doesn't always pan out. So I was told before I take questions, which I'm happy to do, to remind everyone that lunch is not here, that there are it's like we're on a cruise ship and there's a flag, follow me, because the lunch is going to be somewhere different. And that's all I have. But I want to take questions, but I don't want to forget to say that because I was instructed to do so. So, I'm a rule follower. Or is everyone just hungry, which is totally reasonable. All right. Well, enjoy lunch, everyone.